Let's keep it going here with the doctors. We'll bring on Dr. Felix Cabrera, Dr. Doomsday. Of course, from the Physicians Advisory Group. Good morning, Doctor.
Good morning, my sunshine.
There you go. Yeah, we're your silver lining. So, I guess just first of all, Doc, we had heard yesterday that there was going to be a new trajectory coming out, and we heard this from Frank Mansell of FEMA, right? And so he
kind of merging, right?
Right, or there was something where he said that we were going to come out with a new trajectory in the next couple of days. And then we said, well, is FEMA involved? And he said it was more on you guys. So what can you tell us about that, first of all, Doc?
Sure, yeah. So we've been working very, very closely with FEMA, in particular the Region 9 office out of San Francisco. And the key part here is that they are working also with the CDC and Johns Hopkins Applied Physics Lab and in creating these models here. So they're using a lot of the same basic concepts that we had done locally, but applying it to a much more powerful calculator. And we've actually, since we actually been having morning Zoom conference meetings with them over the past 3 days even, and trying to keep refining the model even more and more. And so we got to a point where we felt pretty comfortable, and so you essentially won't be seeing any models that come straight from the Physician Advisory Group and the state surgeon's cell. And instead, because we're merging and we're adopting FEMA's official model. And so that should be coming out shortly. Basically, the bottom line is that it shows two different types of trajectories. One is really the absolute best case, and then the absolute worst case. And they're completely polar opposites. But mainly these models again are used for planning purposes, and it's not necessary to be a forecast. Like to keep reiterating. So that's really what it's being used for. It's being used for FEMA to help make certain decisions as well, and then also for us in terms of how we would need to use these models to help make some policy decisions as well. And so we're actually excited about what we have in terms of having more reliable data.
Doc, how much of or how far a departure is this new model that we're going to see from the models that we saw from the Physicians Advisory Group?
Yeah, I would say this. What the model shows is that we have been extremely effective. And when I say we, I mean everyone on Guam. And that everything that the governor has done to ensure our safety and implement these orders, they very much show its effective measures, and then everyone's cooperation and also their individual efforts and innovative ideas to really help out in their own way. It really has made a tremendous difference, but it's still extremely early. And I think we've made it through this first round, this first phase, and so now we're on to the next phase.
And if we could just stress to people that these trajectories, they're a look at the past 2 weeks, not right. It examines.
Yes.
Right.
Yes. It takes into account basically the past month.
Okay.
The data that we've had over the past month. If you recall, it seems like forever ago, but the very first time we made a presentation during the governor's conference, that was even the first one was over at Homeland, and that we had basically barely anything to go on.
Right.
We were really flying blind. It was a flint in pitch darkness that we finally got a glimpse of what we might be facing. And then a week later or 2 weeks later, we had even more data, and then it showed us how big this monster really could be. And that really scared everyone. And I think, the one time that fear is really important for our survival, I think it's worked. And I think everyone used that fear in a productive way. And I think that's why we're seeing what we're seeing right now, but it's still extremely early. And at any point, if we let off our foot off the gas too quickly, we pump on the brakes in terms of our efforts, we will see this monster resurge very quickly.
Let's switch over to this whole plan for community testing.
Sure.
And from your understanding and the discussions that you've had, how is this all going to work? And are we realistically going to see this ramping up this week?
Yeah, so before we had adequate testing. We only had the ability to do as many as 40 tests per day on Guam. So the word out to the community was, if you have mild symptoms, if you don't have any other major illnesses or comorbidities, and if you're not feeling super sick, don't come in, to the clinic. Just, to be seen. Just stay at home and isolate, and don't, really, really practice, extreme social distancing. That used to be the mantra before. That is now going to change. And we have to tell Guam specifically, if you have any COVID symptoms, if you have a loss of smell, loss of taste, if you're having, shortness of breath, cough, fever, any flu-like symptoms, you need to call. You can call into the clinic first, but you now need to come in to get tested right away, because this is now a new phase, because we are increasing our testing capacity, and then now we don't have to just do a blanket suppression in terms of telling everybody to stay away. We now need to know exactly what we're dealing with and be able to understand more of what of the people in the community that are positive that we just haven't been able to capture yet. And so that's going to be an extremely important factor in our ability to reopen.
So we're going to expand the who we're testing to people just showing any sort of symptoms.
Yes, exactly.
Okay.
So the priority is still, of course, the acutely ill, those that are in the hospital. They get first dibs at what what the testing capacity allows. And then the next part of this is anyone who has these type of symptoms, they have to get the rest. And included in that, when there's space available, it's going to go to the first responders. Let me back up. The only people who are asymptomatic, who don't have any symptoms, that are going to get that may get tested are potential high risk contacts of known positives, or some of our first line healthcare workers and first responders. So that's the shift right now. I know everyone's excited and talking about mass testing and drive-through testing and all that, and that will, that's something that's still being considered, and it's something that we are in the very early planning stages of that. But I want to caution everybody that you cannot mistake discussions for decisions. And so these planning discussions are coming along, but then people are hearing them, second, third hand, and then thinking there are decisions that are being made when we're still very much in the discussion process and planning process.
Yeah, you said discussions, but that was announced during a press conference.
Yeah.
So that's why we're asking about it. Like, is this really going to happen this week? And are we going to see 250 tests a day? Are we going to see?
I mean, I get what you're saying, Doc, but at the same time,
just kind of trying to clarify.
Necessarily represent what she truly meant to say. That the goal is, and so we actually know this, and this is something that we're going to talk about during the press conference today. Is what is this 250 number here? Yeah. And it's actually 258. And
that's a day, right, Doc? That's what our goal is?
Per day. And the reason why that number is there is because there's a Harvard School of Public Health study that was published in the New York Times as well, that discussed that that they believe that in order for the country to start reopening, that every state basically needs to be able to do, every state or territory needs to be able to do 152 tests per 100,000 people. So on Guam, that equates to about 258 tests per day. At least a capacity to do that. Not saying that we absolutely have to do that many, but we need to have that capacity to do that or more. I can tell you right now that there's only one state in the union that has met that threshold, and that's Rhode Island. And the next highest is Louisiana and New York State. But we're not too bad. We're about middle. We're better than most states and territories in the country. But we do have a plan to build up to that, and it's very and it looks good, and that's why we're moving ahead at trying to ramp up to be able to do as many. Because now that we're doing the call out to the rest of the Guam, saying, hey, if you have symptoms, you need to be tested. It's no more of this, stay at home and isolate and don't get tested. No, you need to be tested. And so either you come to us or we're going to find a way to come to you. And that's where public health's main arm is. And I won't try and comment specifically on the details of how they're going to go through that. I'll let them speak for themselves on that. But that's because of this paradigm shift that we're having. We're preparing for that, and we have a lot of good news that comes with that. Like, for example, at GRMC, the instrument BD Max that came in last week, we had the kits come in this just yesterday, and so it's going through its validation process, and that's going to hopefully come online in the next 1 to 2 days and be able to start doing actual tests. And that machine alone, theoretically could do 96 tests per day just by itself. And DLS has the same machine. And if there was no limits on test kits and other consumables that are used up in taking the test, you combine two machines there and you supplement what Public Health Lab has and what GMH Labs has, and then we're very well on the way to hitting our numbers. And that's only and then there's still other machines that we have, the Gene Expert that's both at GRMC and Public Health Lab, that are also going to likely come online in the next either later this week or early next week. So bottom line is that we very much have the potential to not just hit the 258 mark, but surpass it by a fair amount.
So this 258 tests a day is for how many days?
Every day.
Every day.
And for how long of a period, Doc? Are we just going to keep?
It needs to be that we have the capacity to do that. And so let me explain that a little bit more. It's because not that we absolutely have to do that many tests per day, but if there's a flare-up, if there are all of a sudden an outbreak in a certain area, that we need to be able to run those tests without delay, and none of this sitting off island and waiting 3 to 5 days for it to come back. That is not going to work in our new phase. They have to be same-day results, and so we need the capacity to be able to do that in order to sort of put these fires out when they do flame. So not that don't interpret the JIC reports that say, oh, we only tested this many this day. We're so far away from that. It's that we just need to be able to have the capacity to do that, but we still want to take advantage of that and increase the number of people that we're testing, so we cast a wider net.
Doc, I just want to go back to the trajectories again. So we had the trajectory that you put out, and now we're hearing that we're going to get another trajectory that is going to take into account all of the data that we've accumulated here in the last month or so. So I guess my question, and maybe you would know, is which trajectory are we spending all this money on? So we're spending all this money to prepare for COVID-19. Are we, preparing and spending relative to the worst case scenario with this, the 700, or the best worst case scenario with 700 deaths? Or are we now kind of readjusting what we're spending on? Because it kind of seems like we're spending like the end of the world. But now the trajectory is saying that maybe it's not the end of the world.
Can I ask a clarification when you asked about the spending? Can you give me an example of what type of spending you're concerned about?
I guess just generally, I don't have the the docs or the numbers. So what's your take on it?
Okay, just wanted to. If there was a specific area of spending that you were concerned about. So first, let me speak directly in terms of like for the build-up in terms of having more hospital beds available on the island. And so what monies are we spending to build that up? Right. The reality is that right now we're not spending much at all. That these are all still in the planning phases. They are theoretical phases. Right now, in terms of increasing the number of beds on the island, we have plans to shift things around, and that we can still do so much of it if we hit a surge. That we can still do much of it still in actual concrete buildings. And we're talking about, changing Guam Memorial Hospital to be 100% COVID bed hospital, including surgery center and how it will complement, and then even using nearby hotels. So those are all part, and so we're not spending any money to transition these right away. But if we start seeing an early surge before GMH fills up, we will start getting the other parts ready. So there's no money spent in that, except for maybe just the evaluation of the from making sure that these places are adequate, and then having but the materials that we need to at least do with the initial surges is here on island. So we're not ordering anything major additional. That is only going to be for to care for 2,000 6,000 whatever patients. We're not spending monies on that at this point. It's just more it's the planning part.
Mm-hmm. What about these alternate care facilities with the FMS inside? There are two sites. Is that still that's still what we're looking at?
Yeah. So these FMS beds in particular, they have a fair amount of requirements to use them, and so but they would ideally still be used within actual buildings themselves. So that's why the options of some of the ballrooms at nearby hotels. UOG is brought up, Calvo's Field House is brought up a lot, but the reality is that it's very far away. Mm-hmm. It's over a 20-minute drive, and that makes a big difference when we need all when the resources are centrally located at GMH, and in terms of
I know over the weekend we saw the pictures of the National Guard. I think it's the Red Horse Squadron. They were doing an assessment outside in the parking lot.
Yes. Yeah.
Right. And so have we decided where these two alternate care facilities
we have Dr. Louis Cruz, who's a major in the Guard, is spearheading this process in terms of what the build up would look like. And so it's very meticulous, and it has a lot of detail in terms of when things will be triggered. And now we're not necessarily using dates to trigger because of how variable the models are giving us in dates. It's more of a trigger in terms of capacity. Once we reach this capacity in one area, it triggers the setup for the next one. But what the models tell us is also at the worst case scenario, what rate are we dealing with? How fast might we reach our peak? And so that's what the worst case scenario is good for, is that it just tells us how quickly we have to ramp up, but we have the plans that are there, and it's an incredible effort between everybody that's part of this planning to have this drafted up, and it's great. FEMA really appreciates what's been done from the Guard side, and it's really it makes things very clear from what our goals are.
Right, I was going to say, FEMA, we call him FEMA Frank, but Frank Mansell, he was taking us through the process and how, you'll have these two alternate care facilities / FMS stations set up, or at least prepared and ready to go. And then they're going to bring in, I guess, the medical personnel to HHS will bring in the medical personnel to staff these.
Yes. And so that's exactly right. And there's no way, so the first thing we're trying to do is just trying to identify a potential bed space, and then the staffing part is where we would really need their help, and that's a big part of it. But I wanted to take that analogy, building up and thinking about beds, and then think about staffing. And I want to use that analogy to think about testing. So in testing, when we're talking about the ability and capacity to do tests, that's just like making sure that we have the bed capacity in a hospital. Mm-hmm. The personnel to take care of those beds, when you use that analogy with testing, it's making sure that we have the test kits and the reagents, the supplies to run those tests. So when we talk about 258 tests per day, that's just ensuring that we have the machines can handle that, right. That they can take on that load here locally on the island. And that right now it doesn't look like the personnel may be much of a limiting factor in terms of the medical technologists that run these tests. But it's really the rate limiting step will truly be the testing kits and the supplies that come with it, and even the supplies to take the samples.
So, Doc, we had the governor, Linda, say yesterday that they want to be able to start conducting up to 250 tests a day and more as the capacity increases. But you're now saying that that's not really the case, even though they said they want to conduct up to 250 tests a day. You're saying that it's more about having the ability to conduct that many tests a day?
Yes, and I want to be, I want to caution and I want to make sure there's no mincing of words here, that what we're mainly, the first step in that has to be the collecting the samples. before you even get to there. So what do we need to do to build up to even collecting that many 258 samples per day? So again, it goes back to the call out to the rest of the public. If you have any symptoms, you need to be tested, and you need to be tested either at one of the second tier clinics like the AMC, SDA, FHP, or going to public health, any one of the community health centers, and getting tested there. And that's extremely important. So that by itself will increase the samples, and then we'll figure out how to get those tests done in the most expedited fashion possible. And the reality is that even though we don't want to send these off island, if it needs to be at least from the early phase, then we'll do that. But it's not going to be a perfect system, and it will continue to grow. And so what I really want to say is that I'm not somebody who's takes not comfortable really saying listing my credentials here, but I think it's important for the point I'm about to make is that aside from being an internal medicine physician and I actually have a degree in medical technology and laboratory medicine, I list these credentials only to make the point that even for me, testing is very complicated. And I'm having a hard time myself wrapping my mind around every part of it, every aspect of this, especially in this very rapidly developing and new setting that we're in. But that being said, it seems like everyone's an expert in testing now, and the media, you guys are doing a great job trying to consolidate this and broadcast this back to the public. But it's everyone else outside of that's trying to push their agenda onto certain parts here that may not be conducive to doing the testing in the most responsible way.
Like who, Doc? So, can we get some names?
Not at all. but I think it's it's clear that I am not a full expert on all these aspects, but given the mix of experiences I have, I play a role in this. There are other people that play a very essential role in this, and they are the best that we have on the island and close to it as actual major experts on this. And we have to rely on them, and we have to rely on their recommendations. And everyone should really be allow some patience to let this process go through, because we are in this for the long haul, and we're talking about months. And so to get excited about doing a lot of things right away is not. It's not it may not be necessary, and number two, it may be dangerous.
So basically, Katunadza, guys, just stand down. Let's figure this out. Mm-hmm. It's not all going to happen today.
And do it right.
Yes, and do it right, because the one thing we will not have on our hands is us moving quickly and then having deaths on our hands because of it.
Okay.
Right. And so that is clear. The governor has made that clear, and so that is going to be our order of march. And so we want to do this, because we are here for the public. We are here to do what we can to protect them. But we understand that there are a lot of other issues that we have to take into account, including the economic impact here. But the economy will never recover if we still keep adding up deaths.
Yeah.
And so
dead people can't spend money.
Exactly. And so that's the part here. And right now the drafts of and it's okay to have discussions about reopening, and that's good. We need to start planning, because it's gonna take us a while to really start peeling a lot of these layers off and figuring out. But what's good is that this task force that's focusing on reopening, they're really heavily relying on the medical recommendations on when trigger points are hit. Mm-hmm. And when check marks are made in terms of, if we do this, we can move into this section of the reopening and peel off these parts here. If we fail at a later time of meeting these things, then we roll back.
Okay.
So, okay, Doc.
Are you going to be at the press conference at 1?
I am.
Okay.
All right. We'll think of some nice questions for you.
Okay, please. Softballs, please.
All right, Doc. Thank you.
Thank you, Doc.
Thank you.
Okay, God bless. Wash your hands.
All right, you too.
Okay. Okay. 7:59. Guys, we're just going to go to a real quick break, and we're going to flick the switch and jump on to KUAM TV 11. It's 7:59 again. We're KUAM FM, Hagatni, Guam, containing COVID.
Be healthy. Be informed with ITD.